Anatomy and Physiology of Pregnancy. This actually, a lot of this information you already know about, because some of the changes that happen in pregnancy, we already talked about in postpartum, things that go back to normal. So this should be one of the easier PowerPoint slides for you. Basically, we're going to talk about the importance on lifestyle choices and choices related to family planning. And basically, we're again talking about optimal pregnancy outcomes. Well, how does one determine pregnancy? We use the biochemical marker for pregnancy, which is the HCG. And so we can detect that very early on now. There are some pregnancy tests that you just miss your period and they can probably detect it. They can also do it by blood test. But what we're looking for is the HCG, which will determine pregnancy on those pregnancy tests. The most common error on some of this pregnancy tests is testing too soon. I know that there are some on the mail that you can even get in the mail that, oh, they test really early on now. And of course, there's one line for negative and 2 lines, which is a positive. That gets posted. I'm pregnant. Well, I think we should run a pregnancy test just to make sure. And this is interesting because, you know, whenever people go to procedures and stuff, a lot of times before surgery and everything else, they will perform a pregnancy test because many people don't know that they're pregnant and they really are. So, yeah, interesting. This is really important. We really need to confirm pregnancy. Many of you haven't seen one. This is a wheel that we used to use and sometimes still do. If we put their last menstrual period, we roll this to their last menstrual period date, then it will tell us what their gestational age is at this time, and then also what their due date is. But nowadays, we can determine pregnancy basically by the computers. We put in their first menstrual period, and the computer will calculate their due date and their gestational age. But if we don't have a computer or the wheel, we can always use Nagel's rule, which is also in another PowerPoint, which means you probably should know how to calculate. If you take the first day of your last menstrual period, you subtract 3 months and add 7 days, you'll get the expected due date. So the first day of the last menstrual period was June 14th. Minus 3 months, you got March 14th, and add 7 days, and it's March 21st. We already talked about the importance of preconception care, getting good, making sure you're in good health before you decide to get pregnant, and prenatal care begins after the first period. When we speak of pregnancy, we speak in trimesters. The first trimester is 1 through 13 weeks. Second trimester is 14 to 26. The third trimester is weeks 27 to 40. And just know that there's 3 trimesters. I don't think you need to memorize the weeks. Well, we already talked about GTPAL, so just go ahead and review some of your notes. You should be doing these on your clinical SBARs too for practice, and refer back to your notes when we learned about this in week 1. Now, interesting enough, we could do a pregnancy test, but most women think they're pregnant or have clues that they're pregnant before they even take a pregnancy test. And these are presumptive. They're changes felt by women. So a lot of women will say, I think I'm pregnant. And if I ask them why, they'll say, well, I feel a little nauseous. I feel a little tired, feel fatigued. My breasts are a little sensitive. So it's things that they're thinking. But if I ask you, well, they're presumptive because have you ever been nauseous and not been pregnant? Well, yes. Have you ever been tired and not been pregnant? Yes. So these are presumptive. You know what I mean? Have your breasts ever been sensitive and you've not been pregnant? Yeah. So there are changes felt by women, but they're presumptive. But some women really know when they're probably pregnant. Probable changes are changes observed by the examiner when he does a vaginal exam. He can tell by the cervix and the uterus. And we'll talk about those. And the positive signs are, well, if I do an ultrasound and there's a baby in there, it's pretty positive you're pregnant. Or if I see the baby moving and you feel the baby moving, you're probably pregnant. or positively pregnant. So presumptive signs are those that suggest but do not positively indicate pregnancy. Probable signs are strong indicators of pregnancy, and the positive signs is the absolute confirmation of pregnancy. So presumptive are changes felt by the woman, which includes breast changes, missing your period. And I can ask women, have you ever missed your period and not break pregnant? They would probably say, well, yeah. Nausea, some vomiting, and again, you can have that and not be pregnant as well. Urinary frequency because the bladder is sensitive, and fatigue. So these are all presumptive signs, just changes felt by the woman. And then we got the probable signs, which are changes observed by the examiner, which could be your healthcare provider, of course. So there's physical changes in the uterus, which includes the Hagar sign, which is the softening and compressibility of the lower uterine segment. Ballottement is about after 16 weeks that the healthcare provider taps the cervix, the baby will go boing, boing, boing. And the positive pregnancy test, because that's probable because we have had some false positives before. So here's the Hagar sign, which is the softening of the lower uterus, an internal exam. Ballottement is after, it's 18 weeks, where you tip on the cervix and the baby goes boing, 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 boing. The Goodell sign is another sign, which is the softening of the cervical tip. And the Chadwick sign is the deepening color of the vaginal area because of the increased vascular blood supply to the area. It has more of a bluish appearance. The positive signs are those signs that are attributed by the presence of the fetus, which includes, well, if you get fetal heart tones, if you feel the baby moving, or you can actually see the baby moving on ultrasound, those are positive signs of pregnancy. So just become familiar with the presumptive, probable, and positive signs of pregnancy, which the presumptive is changes felt by the woman. Probable, those that are observed by the examiner, and the positive are, well, there is a baby in there. I see it, or I can feel it, or hear it. And of course, this isn't real, but I mean, if you see, that would be a positive. That's a baby's foot, but no, that would never happen. That would be a uterine rupture. But anyway. And here's a kind of a study all, slide. Here for prenatal care, you can see what the presumptive signs are. Quickening is just, you can feel the baby moving. I wouldn't, but anyway, go with presumptive, and then you've got the probable, and then you've got the positive signs. You've got pregnancy tests with the hormone levels. You've got the lab tests that they take. You've got the Nagel's rule, history and physical, the GTPAL. So that could be a useful slide to study off. Now we're going to talk a little bit about the changes that are observed in pregnancy. And again, here would be one slide, study all. You can see all the changes with the respiratory, breast, GI, vaginal changes, skin, endocrine, uterus, urinary, cardiovascular. So let's take a look at some of these and see which ones that we should pay attention to. Again, pregnancy affects all the major systems. The uterus changes in size, shape, position, and of course, that's just pretty logical. The baby grows, the uterus goes. It is stimulated by the high levels of progesterone and estrogen. The fundal height measurement is sometimes used to estimate the duration of the pregnancy. And lightening occurs between weeks 38 and 40, so the fundal height decreases as the fetus begins to descend and engage in the pelvis. So here's just the uterus growing. It's enlarged during pregnancy. On the inside, we can also see on the outside that we do fundal height, and that's measuring from the suprapubic all the way up. And if that measured 40 centimeters, that would mean she's 40 weeks. If it measured 38 centimeters, then she would most likely be 38 weeks. And so it's basically a screening tool. So let's say if maybe she's measuring 35 centimeters here and she's actually 38 weeks, they would probably get a growth ultrasound to see why the baby's measuring small. The uteroplacental blood flow is dependent on mother, and we know that because we know if mom has low blood pressure or high blood pressure, it affects the baby. But that uteroplacental blood flow will increase as the uterus grows. We already talked about some of the changes with pregnancy on the cervix and the vaginal area when we talked about the probable signs observed by the examiner. There's the Goodell sign and the Chadwick sign. And sometimes there's just a slight gray mucousy discharge with a musty odor when you get pregnant. And then the mucus plug that actually forms in the canal to kind of plug it, fills the endocervical canal. And then there's changes in the breasts. They increase in sensitivity, tingling, heaviness. The nipples and the areola become pigmented, and the blood vessels become more noticeable. And colostrum can be seen in some women as early as 16 weeks. Cardiovascular-wise, the heart is pushed up to the left and push up and to the left. Blood volume is increased. Murmurs are sometimes common, and there's a slight increase in the pulse with pregnancy. So the blood volume increases all the way up, maybe like 30 to 50%. You may have a slight increase in pulse between 10 and 15 beats. We know that the clotting factors increase, which helps prevent hemorrhage for delivery, but it also increases their chances of DVT, which we talked about. Physiological anemia occurs as the red blood cell mass increases. The blood pressure should basically remain pretty much the same. Think about this, and when we talk about hemorrhage, this is why 500 to 1,000 milliliters of blood is pumped to the uterus per minute. Okay, supine hypotension sometimes is a problem when people stand up, sit down really quickly. They get a little dizzy. Hemoglobin of less than 11 indicates anemia, which is sometimes with a problem. A lot of women get anemic during pregnancy, so we keep a close eye on their CBC, which includes their H&H. Blood pressure should be pretty much the same, but if it increases, of course, we normally think of preeclampsia. We know that the blood pressure is usually lowest when they're lying on their left side, and we already talked about compression of the vena cava and how that can harm baby, and I have a picture of that later. And then supine hypotension syndrome occurs when they get up real quick from lying down to standing or whatever, and they feel faint. So we just encourage women to sit up slowly if that occurs. And here's the vena cava, and we don't want to compress the vena cava. So we usually have patients not lie flat on their back like this one is, but that's what happens. It compresses the blood vessel there. Again, blood volume increases. Physiological anemia is common. WBCs also increase, if you noticed that when you got your labs on your pregnant women. And then increased blood clotting factors, which leads to thrombosis. And those we've already talked about. I'm going to make you memorize too much. It seems like you're getting a lot of information, so I'm aware of that. You have to memorize statistics. Tendency for thrombosis: avoid sitting for long periods of time, change positions frequently, sometimes some compression hose, at times we may use anticoagulant therapy if it is a problem, particularly with those that are prone for blood clots. O2 needs increase due to the acceleration of the metabolic rate, which is about 20%. Again, don't get too mixed up on statistics, but metabolic rate does increase, which increases the oxygen demands. The ligaments of the rib cage actually relax due to the increased estrogen levels, and the diaphragm is elevated. And sometimes patients have a hard time catching their breath because everything's getting squished as the baby grows up. Nosebleeds and nasal stuffiness are common, and they're related to the increased estrogen levels. So estrogen causes a lot of things, but one of those is the nosebleeds and nasal stuffiness. So we just let patients know that it's okay and just to be cautious with those nosebleeds. Frequent urination is common, particularly in the first and third trimesters. And the first trimester is bladder sensitivity, and of course, third, the baby's playing, is putting a lot of pressure on that. And patients are prone for urinary tract infections, and they're checked for that every time they go into their prenatal visit. And of course, educated on UTIs. The kidneys are working harder. We do know that protein in the urine is abnormal, and we would work them up for preeclampsia. There's the bladder changes. And now we're going to look at some of the changes that occur with pregnancy. And sometimes people get a little bit of pregnancy rash, pruritus, and let's look at some of the others. We already saw this when we talked about postpartum. And we know that that's due to pigmentation, and most of the time it will fade and disappear after the patient is no longer pregnant. It's due to pigmentation changes. We already talked about the linea nigra, and we know that that will fade or disappear, but sometimes women have it anyway, even when they're not pregnant, and that's a normal finding. Stretch marks, which occur, sometimes they will fade a little bit and get a little narrow, but those those will pretty much stay after pregnancy. Spider veins, same thing, they will stay after pregnancy. Sometimes they occur with pregnancy. Something to remind you of afterwards of the pregnancy. Also, the musculoskeletal difference, we'll talk about some of those changes. There's lordosis, which is common, and that's why people get lower back pain and complain about lower back pain. And they have that waddling, and the center of gravity shifts for them. Just encourage them to rest. Yoga is also helpful. Carpal tunnel syndrome sometimes happens. Tension headaches occur, lightheadedness. Some people may get muscle cramps and at night, and we encourage them to take calcium and their prenatal vitamins, which has also magnesium in that. Carpal tunnel syndrome, I had a doctor friend that had that and had a hard time doing deliveries, and hers went away after delivery, and some people have a problem even afterwards. GI system. The gums appear red and swollen. They bleed easier, and again, just like the nosebleeds, they're caused by elevated levels of estrogen, and of course we would encourage them to use a soft toothbrush. Due to the delayed gastric emptying and the reduced tone of the esophageal sphincter, sometimes women will complain of heartburn, which is also caused by the progesterone. Decreased motility in the large intestine sometimes causes constipation and hemorrhoids, and we talked a little bit about that. And again, sometimes compression hose will help that, and also hemorrhoid cream and witch hazel. Gallbladder emptying time is prolonged, which may lead to stone formation. So we are totally aware of that with patients, and we go on, we try to manage the symptoms. And patients have an increased thirst and appetite when they're pregnant, unless they're nauseous. And we already talked about hyperemesis. We use a lot of Zofan and IV therapy to correct fluid and electrolyte imbalances when necessary. The endocrine system, we talked about the metabolic rate increasing, O2 consumption increases. Women always complain about feeling hot and turn off their air conditioners, and that heat intolerance is due to vasodilatation and heat production. And the thyroid gland actually enlarges slightly during pregnancy. We talked about hormone levels, progesterone and estrogen. We talked about these hormones, and we also talked about them when we talked about placental and fetal development. We know that estrogen increases vascularity, and progesterone maintains the pregnancy. The HCG is what we use to detect pregnancy, and relax and softens connective tissues, and relaxes pelvic joints. Changes in pregnancy. There's a decreased sex drive due to fatigue and nausea and vomiting and physical discomfort in the first trimester of pregnancy. Mostly physical discomfort would be in the last trimester. Frequently asked questions, can I drink alcohol in pregnancy? And we would say no alcohol. We don't know what is safe, so no alcohol in pregnancy. Mood swings are normal because they're caused by hormonal changes. We already know if exercise is okay in pregnancy, what you were doing prior to pregnancy, you can do afterwards. Just maintain fluid and calorie intake. Exercise, they suggest beginning with walking. Baby does respond voices in utero, and you can tell that probably about 24 weeks. And if patients are at risk for STIs, we encourage them to use condoms in pregnancy. Some people, when they get pregnant, they don't. They acquire STIs because they're wearing condoms not to get pregnant. So if they have a history, then we should encourage them to use condoms if needed with per history. The warning signs we warn people about in pregnancy is to contact their healthcare provider if there's any bleeding, decreased fetal movement, or an alteration in their fetal movement, and if they are leaking any vaginal fluid. In the office visits, they're always checking the fetal heart tones, vital signs. They check the urine. They check mom's weight. They check for fetal movement. They check the fundal height, and they educate their patients. These are the prenatal labs and tests that they do. We already talked about the CBC. They check for all kinds of STIs. They do a pap smear. They test for rubella, hepatitis B. They check for their blood type, their glucose levels. They do a UA. They do a TB screening, torch screening, alpha fetal protein, which is testing a screening test for neurotube defects and Down syndrome. They check for group B strep and HIV as well. They will also do ultrasounds. Know that domestic violence is more common with pregnant women than the general population. And it's most likely related to the partner feeling a sense of lack of control or power. So we screen all our patients for domestic violence. We try to screen our patients for substance abuse. We look at those who are at a higher risk as well. And we screen, we try to educate as well. Usually they visit every month from 4 to 28 weeks. The gestational diabetes screen is somewhere between 24 to 28 weeks. And then from 28 to 36 weeks, they go every 2 weeks, and then every week from 36 months to delivery. And that would be on a normal patient. If they're high risk, they may go more often. And then the postpartum visit at 6 weeks or earlier. And yeah, there's a lot of visits involved in being pregnant for prenatal care. Any questions? Just write them down, and we'll probably get to this one, I would think, next week. So have a great day and stay well. Thanks.